VHL is an inherited cancer predisposition syndrome. So it's inherited in an autosomal dominant fashion. Affected individuals are at an increased risk for developing tumors at multiple sites. Some of these tumors are malignant and can metastasize if not managed appropriately early on in their course, while some other tumors, although not malignant, can cause a lot of problems by virtue of being in locations where they can affect function of the organs they're affecting. Organs most commonly affected include the kidneys, where we see bilateral, multifocal, clear cell kidney cancer. We also see renal cysts manifest as part of this condition. Renal tumors, if left unchecked, can become metastatic, as can pancreatic neuroendocrine tumors, which is one of the manifestations in the pancreas that we worry about most, although you can also see cysts in the pancreas. Patients can also develop pheochromocytomas and paragangliomas. And in the CNS, mostly in the cerebellum, but also sometimes in the midbrain and other areas of the brain, as well as in the entirety of the spinal cord, can develop these highly vascular tumors called CNS hemangioblastomas. Hemangioblastomas are also a feature of the ocular manifestations of VHL. As you can imagine, tumors growing in the CNS or in the eye can cause functional problems. You can have neurologic deficits from these tumors that are growing unchecked, or your vision can be threatened by retinal hemangioblastomas. Patients tend to get tumors at varying stages of their lives, and some manifestations tend to occur earlier than others. But most patients are at risk for developing tumors throughout their entire life. The way we managed VHL until recently was to address each tumor or each organ system individually when we sense that they may become a problem. And what do I mean by that? So if you have kidney tumors, years of treating patients with VHL has taught us that if these tumors are allowed to grow beyond 3 centimeters, they're more likely to metastasize. And the larger they get, the higher the risk of metastatic disease. And so the management strategy then became to try and remove these tumors once they reach that 3 centimeter threshold. Now, it's not an absolute, written in stone number, but it is an idea. It gives you some idea of the threshold at which surgical intervention is typically recommended. Size criteria are also applied for managing patients with pancreatic neuroendocrine tumors. While tumors in the CNS and eyes are typically managed based on their location and their likelihood of causing symptoms. We sometimes in the CNS wait until they start causing symptoms before we remove them. Management of these patients with these kinds of surgical interventions is generally effective and serves at least some of the purposes that we want to accomplish by removing these tumors. But they don't cure these patients. Patients continue to develop new tumors throughout their life. Yeah, you can go in and take out one tumor, but then 2 years later, you may see another tumor close to where you removed the previous tumor. And then you have to, at some point, go back and remove those tumors as well. And in fact, if you look at the lifetime of a VHL patient, many of them would have undergone multiple surgical procedures, sometimes in the same organ. But it's very typical to see them going from one surgery to another during the entirety of their life. So it's really desirable to have something other than just surgery to manage these patients. There hasn't been a viable option to do that until recently.